Rahim. So today's topic is ECG changes in hyperkalemia. Let's talk about ECG changes in hyperkalemia, right? So in hyperkalemia, we know that there are various causes of hyperkalemia like tumor lysis syndrome, like rhabdomyolysis, it can also happen after electrocution. So there are various causes of hyperkalemia, and one of the chronic cause of hyperkalemia is chronic kidney disease, right? So in ECG, if we get the ECG done in these patients, so the finding that can be prominent in these patients is tall tented T wave, right? So tall tented T wave will be like that of this is called as tall T wave. So you can see here this is PQRS complex. Then you can see that there is tall T wave in these patients. And the next finding that can happen in these patients is the ST segment elevation. You can see that from the from the baseline, the ST segment is moving upward, right? So we're going to see ST segment elevation along with that. And after that, the next ECG finding will be P wave amplitude will be decreased or it will be absent. So you can see that here there is no P wave in these patients, or the amplitude of P wave will be less than 2.5 small scales. The next finding you're gonna see is the PR interval prolongation. So whether it is hyperkalemia or hypokalemia, in both of these we're gonna see the PR interval prolongation, right? So you can see that if it is more than 3.3 to 5 small scale, we're gonna say that it is prolonged, right? So prolonged PR interval, right? So along with that, you can see that there is ST segment elevation and hyperacute T wave, right? The next finding you're gonna see is the broad QRS complex, right? So as the value of the potassium goes up, there will be we're gonna see the ECG changes like that. Okay, it will be broad QRS complex. So you can see broad QRS complex. Along with that, you can see the hyperacute T wave, right? And along with that, when potassium value is more than 8 milliequivalents, we're gonna see the sine wave pattern in these patients. So you can see the sine wave pattern, right, in the hyperkalemia. And right, so if we talk about the depolarization and repolarization of myocardium, so we know that we have sodium influx, then there is potassium efflux, and there is calcium influx, right? So after that, in relaxation phase, there is potassium efflux. When potassium is more outside, so this relaxation part won't happen, right? So there will be diastolic arrest, right? So there will be diastolic arrest in hyperkalemia, right? So that will be because of diastolic arrest of the heart, right? So how we're gonna treat this case, right? So in this case, we'll have to give injection calcium gluconate. We know that calcium causes contraction, right? And potassium causes relaxation. So to antagonize the effect of potassium, we're gonna give the calcium gluconate to this patient, right? So it will be 10% of calcium gluconate diluted in 10%, 10 ml of normal saline, and it is given IV slow over 10 minutes, right? So there is rule of 10 in that. The next thing is to give the insulin drip, right? So we'll have to give along with that of glucose, right? So we have to add glucose because insulin is going to cause hypoglycemia in these patients. So they may die of hypoglycemia, but not because of hyperkalemia. So we have to add insulin along with that of glucose, right? So basically we're gonna internalize the potassium into the cell, right? And to potentiate the effect of insulin, we have to use the salbutamol nebulization, right? So along with that insulin drip, we will have to go for the salbutamol nebulization, right? So this insulin drip is going to internalize the potassium. It's going to reduce the potassium by 0.5 to 1 milliequivalent per hour, right? So if there is chronic hyperkalemia, we're going to treat with that of patiromer. There is a drug that is called as patiromer. We're not going to use these drugs, right? We're not going to use the calcium gluconate, and like that of chronic hyperkalemia can be seen in CKD patients, chronic kidney disease patients. So we're going to use a patiromer, right? Potassium binding resins in that case, right? And the next step we're gonna use is the injection Lasix, right? That is furosemide. This is gonna cause a loss of potassium, that is called as caliuria. So if all of these fail, we're gonna go for hemodialysis, right? So this is most effective method for the removal of potassium, right? So that's all about the hyperkalemia component. And the ECG component related to that, we're gonna see the hyper tall T waves, right? Then there will be ST segment elevation, right? So as potassium build up in the body, so we're gonna see the various findings in these patients, right? So you have to remember that there will be PR interval will be prolonged in both hyperkalemia and hypokalemia. The next topic will be ECG changes in hypokalemia, right? So that's all for today.